Imagine a patient, a healthy 25-year-old. They walk into A&E on a Tuesday evening. They're sweating, their heart rate is absolutely through the roof, and well, they are really struggling to breathe.
It's a terrifying presentation.
Right. And if you look at their chest imaging, you see something awful. There's a massive raging infection surrounding their heart, deep within the mediastinum. The cardiothoracic surgeons are prepping for an emergency sternotomy, which, is a procedure with an incredibly high mortality rate in this context.
Yeah, it's an absolute crisis.
Exactly. So you look for the source of this catastrophic chest infection. Was a punctured lung, a traumatic wound to the thorax? No. You trace the timeline back 48 hours, and you find the culprit. It was a toothache.
A toothache.
Just a completely mundane, slightly infected lower right molar.
It sounds like a medical thriller, doesn't it? But it is a very real, very lethal clinical scenario. And it begs the ultimate question: how does a localized pocket of pus in the jaw defy gravity, bypass the dense muscular structures of the neck, and plunge directly into the chest cavity to threaten the heart?
Which brings us to the core of our deep dive today. Welcome. If you're a medical student navigating your early clinical years, a surgical or dental trainee staring down complex head and neck procedures, or, just a seasoned clinician brushing up on your applied anatomy, this deep dive is custom tailored for you.
Absolutely.
We're using Chapter 22 of Haidt and Gartner's textbook of head and neck anatomy as our structural spine today. But let me be clear about our mission. We are not here to regurgitate a dry list of anatomical attachments or origin and insertion points for you to rote learn.
No. That is what flashcards are for.
Exactly. We are here to build a dynamic, three-dimensional spatial mental model of the head and neck. We are mapping out the hidden planes of spread, so remember to read alongside the chapter as we go.
Right. Because usually when we think about building a house, we spend all our time admiring the visible architecture. We look at the sturdy oak floors, the solid load-bearing walls, the beautiful windows.
And in human anatomy, we naturally do the exact same thing. We focus on the impressive, powerful muscles, the dense structural bones, the highly visible, pulsing blood vessels.
We treat them as the rooms and the furniture. But if you want to understand how a fire actually spreads through a house, well, you don't look at the furniture. You look at the drywall. You look at the floorboards, the air ducts, the hidden crawl spaces.
You look at the fascial planes. If the muscles and bones are the rooms, the fascia is the drywall and the ductwork. It provides essential organization, keeping everything in its proper place, but in doing so, it creates these hidden corridors. Not all danger lies in what you see. Sometimes it lies in the spaces in between.
And that is the anchor we need you to keep firmly in your mind for the duration of this deep dive. Anatomy is the study of structure in service of function.
Structure in service of function.
Right. The fascia of your neck is not just biological packing peanuts. It is an exquisitely designed connective tissue system. It allows your neck and head to function, to let you swallow a piece of tough bread, to let you crane your neck to check your blind spot, to let you speak without your internal organs, vessels, and muscles generating immense, damaging friction against one another.
It facilitates frictionless movement.
Precisely. But it is exactly that functional structure, those exact sliding planes, that shape how disease happens, how infections spread, how surgical interventions must be meticulously planned, and ultimately what the patient's outcome will be.
Right. Structure dictating clinical pathology. So let's unpack this. Before we can even begin to understand how that dental infection suddenly threatened our hypothetical patient's heart, we have to lay down the foundational architecture of the cervical fascia, the fascial layers of the neck.
Right. The core framework.
Yeah. And we divide this architecture into two main categories, the superficial cervical fascia and the deep cervical fascia. Let's start from the outside in. If we peel back the skin of the neck, the very first thing we encounter is the superficial cervical fascia.
And we really have to conceptualize what superficial fascia actually means biologically. It is essentially a layer of subcutaneous connective tissue. It surrounds the entire neck in a cylindrical fashion, sitting immediately deep to the dermis.
But it's not a rigid fibrous shell, is it?
No, not at all. It contains a significant amount of adipose tissue fat, and it is relatively loose.
Which makes perfect sense functionally. When I look up at the ceiling, the skin on the front of my neck stretches immensely. When I tuck my chin to my chest, it folds.
Exactly.
If the skin were rigidly tacked down to the deep structures like the thyroid cartilage or the trachea, every time I move my head, I'd be pulling directly on my airway.
Yeah.
This superficial layer acts as the absolute sliding boundary between the outside world and the structural moving engine of the deeper neck.
It allows the cutaneous layer to glide, But it's not completely empty tissue. It houses some very specific structures. Most notably, it contains the platysma muscle anterolaterally.
Ah, the platysma, that incredibly thin, broad sheet of muscle. If you clench your jaw, pull your lower lip down, and tense your neck, you can actually see the vertical bands of the platysma popping out right under the skin.
You can. It's a fascinating evolutionary remnant, actually. In many mammals, a similar, much more extensive layer of subcutaneous muscle called the panniculus carnosus allows them to twitch their skin to shake off flies.
Oh, wow. I didn't know that.
Yeah. In humans, it's mostly restricted to the neck and face as the platysma, functioning as a muscle of facial expression to convey tension or stress and helping to depress the mandible. Because it is a muscle of facial expression, it logically resides within the superficial fascial layer rather than deep down with the skeletal muscles.
Makes sense. And along with the platysma, this superficial layer also contains the cutaneous branches of the cervical plexus. Those are the sensory nerves that supply the skin of the neck, as well as superficial veins and lymphatic vessels. It's the superficial wrapper.
Exactly. The wrapper.
But the real architectural complexity, the true functional engineering, begins when we strip away that superficial layer and confront the deep cervical fascia.
This is where we start building the walls of the house. The deep cervical fascia is much denser, much more fibrous connective tissue. It is designed for structural containment, organization, and compartmentalization.
And we categorize it into three primary distinct layers, right? The investing fascia, the pretracheal fascia, and the prevertebral fascia.
That's right. 3 distinct cylinders.
Let's take them one by one, because visualizing how they interact is crucial. We'll start with the outermost layer of the deep fascia, the investing fascia, the anterior or superficial layer of the deep cervical fascia. I always picture this layer as a tight, structural collar that completely encircles the neck.
A collar is the perfect analogy. Let's trace its path so we can build it in our minds. Posteriorly, it originates from the dense, bony landmarks of the back of the neck, the spinous processes of the cervical vertebrae, and the ligamentum nuchae, which is that thick, fibrous midline ligament at the back of your neck.
Right.
From that secure posterior anchor, it sweeps forward bilaterally, encircling the entire neck.
But it doesn't just form a simple hollow tube like a piece of PVC pipe, does it? As it moves anteriorly around the sides of the neck, it encounters obstacles, it hits massive muscles, and instead of just sliding over them, it actively envelops them.
It does. As the single sheet sweeps forward from the back of the neck, the first structure it encounters is the massive trapezius muscle. When it hits the posterior border of the trapezius, the investing fascia physically splits into 2 distinct leaflets, a superficial leaflet and a deep leaflet.
Okay.
These 2 leaflets wrap entirely around the trapezius muscle, effectively creating a dedicated fascial sleeping bag for it.
Right. And once it gets to the anterior border of the trapezius, those 2 leaflets fuse back together into a single thickened sheet. This single sheet then spans across the side of the neck, forming the literal roof of what we call the posterior cervical triangle.
And then, as it continues its forward march, it hits the next massive obstacle, the sternocleidomastoid muscle, or SCM, that large diagonal muscle that pops out when you turn your head against resistance.
So it does the exact same trick. The single sheet splits again, wraps around the inside and outside of the SCM, and then fuses back together at the anterior border of the SCM. It then meets its counterpart from the other side at the anterior midline of the neck.
Yes.
It's an incredible continuous system of containment. But wait, why split? Why not just have a single sheet that covers everything?
Because of function.
Yeah.
The trapezius and the sternocleidomastoid need to contract independently and sometimes violently. If they were rigidly bound together by a single, unyielding fascial sheet, contracting the SCM to turn your head would inadvertently pull on the trapezius and restrict your shoulder movement.
Ah, I see.
By encasing them in their own independent sleeves, formed by the splitting of the investing fascia, the body ensures they are structurally secured in place, yet functionally independent. They can slide within their envelopes without snagging adjacent structures.
Structure in service of function. Now, this investing collar doesn't just wrap the big muscles. As it continues anteriorly, it also provides thin fascial coverings that envelop the infraoid muscles, the strap muscles that run vertically down the front of your throat, attached to the hyoid bone above and the sternum below.
Right.
But here is where we need to look closely, because the attachments of this investing fascia create significant anatomical spaces. We'll have to look at where this collar attaches inferiorly, down at the base of the neck.
Inferiorly, the investing fascia attaches to the spine of the scapula, the acromion, and the clavicle, the collarbone. But as it reaches the very front, at the midline, it attaches to the manubrium of the sternum. The manubrium is that shield-like, hard, bony notch at the very top of your chest, right below your throat.
Yeah, if you run your finger down the front of your throat, past the Adam's apple, you'll drop into a little dip just above the bone of your chest. That bone is the manubrium.
Exactly. But the investing fascia doesn't just form a single attachment line along the superior edge of the manubrium. Just before it reaches the bone, the fascia splits once again. One leaflet attaches to the anterior surface of the manubrium, and the other leaflet attaches to the posterior surface.
So by splitting to attach to the front and back of the bone, it creates a literal gap, a pocket, a sealed fascial tent right above your sternum. This is known anatomically as the suprasternal space, or the space of Burns.
And this space is not empty. It's clinically relevant because it contains adipose tissue, usually a lymph node, and crucially, it houses the jugular venous arch. The jugular arch is the horizontal venous connection that bridges the two anterior jugular veins across the midline.
Now wait, let's pause right here because I want to run a diagnostic on this mental model.
Yeah.
This is something that routinely confuses anyone studying this for the first time.
It really does.
We just established that this investing layer is the outermost layer of the deep fascia. It's the rigid structural collar. Yet, when we learn about the venous drainage of the neck, we are repeatedly taught that the anterior jugular veins and the external jugular veins are superficial veins.
Yes.
If this investing fascia is wrapping everything so tightly, creating this boundary, how do these superficial veins navigate it? Are they floating around in the fat outside the collar, or are they trapped deep inside it?
That is a brilliant point of clarification and a very common stumbling block. When you dissect a cadaver, or when a surgeon makes an incision in the neck, it visually appears as though those veins are coursing in the loose tissue between the superficial fascia and the deep fascia. But anatomically, the reality is much more integrated.
How so?
The anterior and external jugular veins actually course within the superficial layer of this investing fascia.
What do you mean by within?
I mean, they're embedded within the actual substance of the fascial sheet. Remember how the fascia split to enclose the muscles? In a similar way, the connective tissue matrix of the investing fascia integrates these veins. They don't just sit on top of it. They are woven into the structural fabric of the collar itself before they eventually dive deep to join the internal jugular or subclavian veins.
That is a massive distinction for a surgical trainee. It means when you are making a superficial incision and dissecting down, you aren't just going to hit fat and then suddenly hit a hard fascial wall. You are going to encounter these major, easily collapsible superficial veins precisely as you are breaching that first boundary of the deep fascial system.
Precisely. If you assume the deep fascia is a safe avascular wall, you will inadvertently transect the external jugular vein.
Okay, so that's the inferior aspect of our collar. The attachments to the sternum and clavicle, and the creation of the suprasternal space. What happens when we trace this investing collar superiorly, up towards the head?
Superiorly, the investing fascia anchors to the prominent bony landmarks of the skull base and the jaw. It attaches posteriorly to the external occipital protuberance, the bump at the back of your skull, and the mastoid processes just behind your ears. As it moves laterally and anteriorly, it attaches to the zygomatic arch, your cheekbone, and the inferior border of the mandible, the jawbone.
But just like it's split around the muscles of the neck, it does something highly complex when it encounters the glandular structures near the jaw. Let's look at the parotid gland, the massive salivary gland sitting just in front of and below the ear.
As the investing fascia ascends toward the zygomatic arch, it encounters the parotid gland. And once again, it splits. It forms a superficial leaflet that passes over the outside of the gland and a deep leaflet that passes deep to the gland. It completely encapsulates the parotid gland in what we call the parotid capsule or parotid fascia.
And this isn't just a loose bag. The parotid fascia is incredibly dense and unyielding, especially the superficial leaflet, which explains why an infection or inflammation in the parotid gland like the mumps or a bacterial parotitis is so excruciatingly painful.
Right.
The gland tries to swell, but the dense fascial capsule absolutely refuses to expand. The pressure builds up exponentially against the sensory nerves within the gland.
It's the anatomical equivalent of a pressure cooker. But the deep leaflet of this parotid capsule does something functionally extraordinary. As the deep leaflet passes behind the gland, a specific portion of it drastically thickens and condenses.
Okay.
It forms a strong, fibrous band that runs from the styloid process, that sharp, pen-like projection of bone jutting down from the base of the skull all the way down to the angle of the mandible, We call this the stylomandibular ligament.
The stylomandibular ligament. Now, why are we zooming in on a single tiny ligament in a deep dive about fascia? Because if we connect this to the bigger picture, this ligament is the perfect example of a fascial derivative creating a definitive clinical boundary.
Exactly. The stylomandibular ligament physically separates the parotid gland, which sits above and behind it, from the submandibular gland, which sits below and in front of it. It is a literal wall between two major glandular compartments.
So clinically, why does a head and neck surgeon care about this wall?
Because it halts the spread of pathology. If a patient develops a virulent infection, or more commonly a salivary gland tumor, within the parotid gland, it will grow and expand. But when it hits that stylomandibular ligament, it hits a roadblock.
It just stops.
Yes. This fascial derivative prevents the tumor from easily spilling over into the submandibular region. It contains the pathology. Conversely, a submandibular tumor won't easily invade the parotid space. It allows the surgeon to conceptualize the disease within a strict, confined anatomical compartment rather than a nebulous mass spreading indiscriminately.
Structure dictating clinical pathology. I
Yeah.
love it. All right, we have thoroughly mapped out the investing fascia. We have our outer structural collar. Now, we need to go deeper into the house. We strip away the collar, and we are looking at the central core of the neck. This brings us to the second major layer of the deep cervical fascia, the pretracheal fascia.
The text also very aptly refers to this as the visceral fascia, which gives you an immediate clue about its function. If the investing layer is the collar, the pretracheal layer is the visceral wrapper.
The visceral wrapper.
Right. It strictly encases the viscera, the highly mobile tubular organs of the anterior neck. We are talking about the trachea, the esophagus, the pharynx, the larynx, and the thyroid gland.
It's a completely different environment. These structures aren't just sitting there. They're constantly expanding, contracting, and sliding vertically every single time you swallow, breathe, or speak.
And that requires a very specialized fascial envelope. The pretracheal fascia is generally thinner and more pliable than the investing layer. Its anterior portion, which lies in front of the trachea, is a thin, filmy tissue. It actually lies deep to the infrahyoid strap muscles and blends anteriorly with the investing fascia we just discussed. Crucially, it completely wraps the thyroid gland, forming a false capsule around it and binding the thyroid tightly to the laryngeal cartilages and the trachea.
Which explains a classic clinical sign.
Yeah.
If a patient comes into your clinic with a lump in the front of their neck and you ask them to swallow a sip of water, what happens? If the lump moves up and down vertically with the swallow, you know instantly that the lump is associated with the thyroid gland or the larynx.
Exactly.
Why? Because the pretracheal fascia binds the thyroid rigidly to the trachea, which is pulled upward during the swallowing reflex. The fascia dictates the physical movement of the pathology.
Precisely.
Yeah.
But while the anterior portion of the pretracheal fascia is clinically useful for physical exams, it is the posterior portion of this visceral wrapper that is anatomically and surgically vital. As the pretracheal layer wraps around the sides of the thyroid, the trachea, and the esophagus, it continues around to cover their entire posterior surface. This highly specialized posterior sheet of the visceral fascia has its own distinct name, the buccopharyngeal fascia.
The buccopharyngeal fascia. Let's really isolate this structure because it's going to be a major player when we discuss life-threatening infections later.
Think of the buccopharyngeal fascia as the back wall of the visceral compartment. It covers the entire posterior surface of the esophagus and the pharynx. It is intimately applied to the superior pharyngeal constrictor muscle, the muscle that actively squeezes food down your throat.
Okay.
Superiorly, it attaches firmly to the base of the skull. And as its name implies, bucco, relating to the cheek, it actually continues laterally and anteriorly to cover the buccinator muscle, the trumpeter muscle of your cheek, attaching to the pterygomandibular aphyx.
So if I were a tiny microbe sitting on the back of the pharynx, looking towards the spine, the very first wall I would face is the buccopharyngeal fascia. It seals the food and air tubes away from the rest of the neck. That's right.
Okay, so we have the outer collar, the investing layer, and we have the visceral wrapper, the pretracheal layer, backed by the buccopharyngeal fascia. The third and final major layer of the deep cervical fascia is the structural backbone of the whole system, the prevertebral fascia.
And this one is exactly what it sounds like. It is a dense, tough, cylindrical layer that encases the vertebral column and the heavy, powerful musculature associated with it. We're talking about the deep muscles of the back that extend the neck, the longest calling muscles interior to the spine, and the scalene muscles laterally.
If the neck were a tent, the prevertebral fascia is wrapping the central pole. It lies deep to the trapezius muscle posteriorly,
Ah.
actually forming the literal fascial floor of the posterior cervical triangle we talked about earlier.
It forms a very rigid muscular compartment. But what makes the prevertebral fascia truly fascinating are its lateral extensions. It doesn't just stay rigidly confined to the neck. As the vital nervous structures exit the spinal cord and head towards the limbs, the prevertebral fascia gets dragged along with them. Let's trace that. The brachial plexus. This is the massive complex network of nerves that exits the cervical spine, runs through the neck, and eventually provides all the motor and sensory innervation to your arm and hand.
Exactly. As the roots of the brachial plexus emerge from between the anterior and middle scalene muscles in the neck, they push against the prevertebral fascia that is covering those muscles.
Hmm.
The fascia yields, stretching out to form a tubular sleeve around the nerves and the accompanying subclavian artery.
Right.
This sleeve of prevertebral fascia continues all the way down, passing under the clavicle and deep into the armpit, where it is known as the axillary sheath.
The axillary sheath. So conceptually, the fascial compartment of your deep neck is continuously connected via this tubular sheath all the way down into your armpit. If you inject local anesthetic into that sheath in the neck, like for a brachial plexus block, the fluid will physically travel down that fascial tube to numb the arm.
It's a perfect example of how fascia creates corridors. Furthermore, the prevertebral fascia also overlies and binds down the phrenic nerve.
Oh, the nerve for the diaphragm.
Yes. The phrenic nerve is the sole motor supply to the diaphragm that keeps you breathing. It descends almost vertically across the anterior surface of the anterior scalene muscle. The prevertebral fascia plasters it securely to that muscle, ensuring this critical nerve isn't easily displaced or damaged during neck movement.
Okay, let's bring our focus back to the anterior part of the neck, right behind the throat, because we need to look at how this prevertebral fascia interacts with the visceral compartment we just built. We established that the back wall of the visceral compartment is the buccopharyngeal fascia. Immediately behind that, covering the spine, is the prevertebral fascia. But the text notes a highly complex, absolutely critical structural adaptation here. As the prevertebral fascia comes around the sides of the neck to cover the front of the vertebral bodies, it does something unusual.
It splits, and this is perhaps the most anatomically vital split in the entire head and neck because the spaces it creates dictate life and death. As the prevertebral fascia sweeps anteriorly, crossing the midline directly in front of the vertebral bodies, it divides into two distinct laminae, or layers.
Let's visualize this. We have the buccopharyngeal fascia hugging the back of the throat. Behind that, we have this newly split prevertebral fascia.
Right. The posterior lamina of this split, the layer that stays plastered tightly against the bone and ligaments of the vertebral bodies, retains the name prevertebral fascia. But the anterior lamina of this split, the layer that moves forward to sit closer to the throat, is given a new name, the alar fascia.
The alar fascia. I want everyone listening to mentally highlight, underline, and circle that term, the alar fascia.
The alar fascia is a thin, delicate sheet of connective tissue. It is loosely attached in the midline to the buccopharyngeal fascia directly in front of it. It extends from the base of the skull down to roughly the level of the seventh cervical vertebra, C7, where it usually blends with the visceral fascia.
We're going to come back to this alar fascia in a few minutes because by splitting away from the spine, it creates two hidden corridors, the retropharyngeal space and the danger space, that are the primary focus of our clinical correlations today. But before we dive into the terrifying spaces, we have to talk about the pipeline that connects all these layers together, the carotid sheath. We've talked about the outer collar, the visceral wrapper, and the spinal cylinder, but running vertically through the neck, flanked by these three systems, is the major neurovascular highway, the carotid sheath. In our house metaphor, if the investing fascia is the exterior wall, the carotid sheath is the main utility duct running from the basement to the attic. It houses the heavy-duty wiring and plumbing. It contains the common carotid artery, the internal carotid artery, the massive internal jugular vein, and the vagus nerve, cranial nerve X. But the carotid sheath isn't just a separate standalone piece of tissue, is it?
No, it is a brilliant collaborative structure. It is formed by contributions from all three of the fascial layers we just discussed. Its anterolateral portion is formed by a medial extension of the investing fascia, with delicate contributions blending in from the pretracheal fascia. The posterior wall of the sheath is formed by connective tissue derived from the prevertebral fascia.
So all three fascial systems reach out and hold hands to form this protective cylinder.
Exactly. It's a composite insulated pipeline. It connects the jugular foramen and carotid canal at the base of the skull all the way down through the neck, blending inferiorly with the adventitia of the great vessels and the fibrous pericardium of the heart deep in the mediastinum.
It's a direct, unbroken fascial tube from the brain to the heart. And importantly, the interior of this sheath isn't just one big hollow cavern where the artery, vein, and nerve are floating around rubbing against each other. It is internally compartmentalized.
Yes, very much so.
It has its own delicate internal fascial septa, separating the internal jugular vein from the carotid artery and isolating the vagus nerve posteriorly.
Which, again, is structure in service of function. You have the common carotid artery pulsing with immense systolic pressure 60 to 100 times a minute.
Okay.
Right next to it, you have the internal jugular vein, a massive, thin-walled, easily compressible vessel. And nestled between and behind them is the vagus nerve, a critical conduit of parasympathetic control to your heart and gut.
That's a lot going on in one tube.
It is. If these three were just loose in a bag, the constant violent arterial pulsation would physically batter the delicate cranial nerve, potentially causing mechanical irritation and bizarre autonomic reflexes. The internal fascial walls mitigate that friction. Furthermore, the fascial envelope around the internal jugular vein is particularly thin, allowing the vein to easily dilate and accommodate massive increases in venous return during exertion.
The engineering is just spectacular. Okay, so we have firmly established the deep architecture of the neck. The concentric cylinders, the visceral wrapper, the spinal core, and the neurovascular tubes. But the human body doesn't exist as isolated segments. The neck has to end, and the head has to begin.
Right, the transition.
The architecture has to ascend, cross the sharp border of the mandible, and adapt to cover the face. This takes us to the next logical phase of our mental model, ascending to the face and the deep face. How does this neat cylindrical cervical architecture handle the chaos of the jaw and the facial expressions?
The transition is stark and highly specialized. We shift from the elegant, long cylinders of the neck into the highly complex, densely packed, irregular compartments of the deep face. But let's start at the surface, just like we did with the neck. Let's look at the superficial fascia of the face.
This is the tissue immediately deep to the skin of your cheeks, your forehead, your chin. It contains the muscles of facial expression, their motor innervation from the facial nerve, and a rich network of blood vessels. But the text makes a very specific, fascinating point here that I want to interrogate. It states that, unlike almost anywhere else in the body, the superficial fascia of the face lacks any underlying deep fascial layer. In the clinical correlations, it explicitly notes that the face lacks typical deep fascia entirely. Now, if I'm a medical student, I'm thinking about trauma. If I suffer a deep laceration on my forearm, the dense, deep fascia covering my arm muscles acts like an internal bandage. It holds the structural integrity of the limb together, even if the skin is cut. What happens on the face? What does this lack of deep structural glue mean when a patient suffers severe facial trauma, like, say, going through a windshield?
It creates a unique and highly challenging surgical scenario because there is no typical deep fascial layer to act as a rigid anchor or limiting binder in the superficial face. The muscles of facial expression insert directly into the skin. When the skin and superficial fascia are lacerated, those muscles continue to contract. Without a deep fascial layer restricting them or holding the tissue planes together, they pull the edges of the wound violently apart. Lacerations and surgical incisions on the face tend to gape open widely, much more so than a similar cut on the arm or leg.
Which raises an immediate practical question for any surgical trainee. How do you manage this functionally? You can't just throw a couple of superficial stitches in and expect it to hold.
You cannot. In other parts of the body, a surgeon relies heavily on deep fascial sutures to take the mechanical tension off the skin closure, allowing for a neat, thin scar. In the face, because that deep fascial strength isn't there, you have to be incredibly meticulous. You must use precise, multi-layered subcutaneous suturing techniques, carefully realigning the dermis and the muscles of facial expression to bear the tension. If you rely solely on skin sutures, the constant movement of the face will stretch the wound, leading to an ugly, widened, hypertrophic scar. The lack of deep fascia demands advanced surgical technique.
Evolutionary speaking, why would we lack deep fascia there?
Because of microexpressions. We are highly social primates. Our survival depends on communicating incredibly subtle emotional states, fear, anger, empathy, through minute twitches of our facial muscles. If our facial muscles were bound down by a stiff, unyielding collagen mask of deep fascia, our faces would be rigid. We traded impregnable structural defense for the vital mobility of social communication.
It makes perfect sense. No drywall behind the wallpaper so the wallpaper can move freely. But as we move deeper into the lateral sides of the face toward the jaw joint, the deep fascia from the neck does continue upwards, right?
It does.
The superficial layer of the deep cervical fascia, that structural investing collar we built earlier, sweeps up over the inferior border of the mandible. And as it does, it splits to create one of the most mechanically intense compartments in the human body, the masticator space.
The masticator space is essentially the high-pressure engine room of the jaw. As the investing fascia reaches the inferior margin of the mandible, it splits into a medial leaflet that runs up the inside of the jaw and a lateral leaflet that runs up the outside. It encases the bone of the mandibular ramus entirely. But it doesn't just hold bone, it completely encloses the powerful muscles of mastication.
The muscles that let you crush food. We're talking about the maxillary muscle on the outside of the jaw, the medial and lateral pterygoid muscles on the inside, and the inferior portion of the massive temporalis muscle descending from the skull.
All packed tightly into this fascial envelope. I like your earlier analogy of a high-rent, densely packed compartment. It is incredibly crowded. Alongside those massive muscles, the masticator space contains the crucial maxillary artery and its branching network, the mandibular division of the trigeminal nerve, cranial nerve V3, which provides all the sensory and motor wiring for the lower jaw, and a large portion of the buccal fat pad, which helps lubricate the muscular sliding.
It is a sealed, high-pressure compartment. It's closed superiorly and posteriorly where the fascial laminae fuse, and attached firmly anteriorly to the maxilla and mandible. And this structural containment is why pathology here is so dramatic.
Exactly. What happens when pathology, like a severe abscess from an infected lower third molar or a tumor from the floor of the mouth, invades the masticator space? Because it is a closed, unyielding fascial compartment, any inflammation or rapid pus generation causes immense internal pressure to build up almost instantly. The fascia will not stretch to accommodate the swelling.
It's the parotid capsule problem all over again, but with worse consequences.
Much worse. This immense pressure physically compresses the mandibular nerve, V3, causing excruciating radiating pain across the entire jaw and side of the head. But more functionally devastating, the pressure and inflammation severely irritate the muscles of mastication. The muscles respond by going into a protective tetanic spasm. This leads to profound trismus lockjaw. The patient becomes physically unable to open their mouth more than a few millimeters. They can't eat, they can't speak properly, and crucially, an anesthesiologist cannot easily intubate them if their airway is compromised.
Which makes a masticator space infection an immediate severe clinical crisis. And adding to the danger, while it is structurally bounded, it acts as a critical junction box. It communicates superiorly with the temporal spaces, and medially it has pathways to other deep spaces in the head. It is a dense, dangerous hub. Now, let's look at the space sitting just below and medial to this, nestled snugly inside the horizontal curve of the submandibular space. This is an incredibly common site for oral infections to pool.
The boundaries of the submandibular space are critical to understand. Superiorly, it is bounded by the mucosal membrane of the floor of the mouth and the undersurface of the tongue. Inferiorly, the floor of the space is formed by the investing fascia as it sweeps from the hyoid bone up to the mandible, covering the anterior belly of the digastric muscle.
But the internal architecture of this space is what makes it fascinating. There's a wide, flat muscle that stretches across the inner curve of the mandible like a hammock, attaching down to the hyoid bone, the mylohyoid muscle.
The mylohyoid muscle is the key landmark here. It acts as an internal horizontal divider.
I was trying to visualize the submandibular space as a large two-story warehouse. The mylohyoid muscle acts as a mezzanine floor, bisecting the warehouse horizontally. Above the mylohyoid mezzanine, but still below the tongue, is the superior compartment, called the sublingual space. Below the mylohyoid mezzanine is the inferior compartment, the submandibular space proper.
That is an excellent spatial analogy. The sublingual space above houses the sublingual salivary gland, the geniohyoid and genioglossus muscles of the tongue, the lingual nerve, the hypoglossal nerve, and the lingual artery. The submandibular space below houses the large submandibular salivary gland and facial lymph nodes. But here is the critical flaw in the architecture. That mylohyoid mezzanine floor does not go all the way back to the back wall of the warehouse.
It's only a partial floor.
Exactly right. At the posterior margin of the mylohyoid muscle, there is an open gap. The fascia does not seal it. This means the superior sublingual space and the inferior submandibular space freely communicate with each other around the posterior free edge of that muscle.
Let's trace the clinical reality of that gap. A patient gets a severe infection in the floor of their mouth, say, from an abscessed lower incisor or a piercing gone wrong. The infection begins in the superior sublingual space. Because it's a tight space under the tongue, the pus needs somewhere to go. It can't go down through the solid mylohyoid muscle.
Right, it can cross the floor.
So it takes the path of least resistance, it flows backward, rolls right off the back edge of that mezzanine floor around the posterior border of the mylohyoid, and drops directly down into the inferior submandibular space.
And it gets worse.
Yeah.
It is not just vertical communication. Because of the anatomy of the floor of the mouth, there is very little fascial barrier separating the left side from the right side near the anterior midline. The spaces communicate bilaterally.
Which sets the stage for one of the most feared presentations in emergency medicine, Ludwig's angina.
Ludwig's angina is a rapidly spreading bilateral aggressive cellulitis of the submandibular and sublingual spaces. Because the infection involves both spaces, above and below the mylohyoid, on both the left and the right side simultaneously, the tissues of the floor of the mouth swell massively.
Oh, wow.
The investing fascia inferiorly is tough and won't yield easily, so the swelling is forced upward. It physically pushes the base of the tongue upward and backward against the roof of the mouth and into the pharynx, completely obstructing the patient's airway. They can literally choke to death on their own displaced tongue with their hours.
It is terrifying, and it is entirely dictated by where these fascial boundaries end and where the hidden corridors remain open. All right, we have mapped out the massive cylinders, the visceral wrappers, the high-pressure engine rooms of the jaw, and the mezzanine floors of the mouth. We understand the rooms. Now we must turn our attention to the spaces between the walls.
The clinical corridors.
Yes. This brings us to the clinical correlations, the fascial spaces and the hidden corridors. These are the potential clefts of loose connective tissue between the dense fascial layers we just built. In a healthy person, they are just slippery gliding planes. In a diseased person, they are the highways for catastrophe. Let's start back in the visceral compartment of the neck.
As we established, the visceral compartment is bounded by the pretracheal fascia anteriorly and the buccopharyngeal fascia posteriorly. Within this compartment, we have potential spaces. Anterior to the trachea, between it and the infraoid strap muscles, is the pretracheal space.
And what are the boundaries of this space? Where does it go?
Superiorly, it is limited by the fascial attachments to the thyroid cartilage and the hyoid bone. So infection here generally cannot spread upwards into the head. But inferiorly, the pretracheal space follows the trachea directly down behind the sternum, continuing seamlessly into the anterior mediastinum of the chest cavity.
A direct, gravity-assisted chute from the front of the neck to the space just in front of the heart. If a patient suffers a penetrating trauma to the anterior neck, or an infection from the thyroid gland breaks out, it can slide right down that corridor.
Yes, exactly.
But as dangerous as that is, the truly notorious spaces, the ones that cause the most lethal complications, are located behind the viscera. Let's talk about the retropharyngeal space.
The text notes that while it is commonly called the retropharyngeal space, a more clinically accurate term is the retrovisceral space because it continues inferiorly behind the esophagus as well.
Let's build the walls of this space. Where exactly is it?
It is located directly behind the throat. The anterior wall of this space is the buccopharyngeal fascia, which is hugging the back of the pharynx and esophagus. The posterior of this space is the alar fascia, that delicate anterior split of the prevertebral fascia we highlighted earlier.
So it's a cleft between the food tube and the spinal fascial wrap. How far does it run?
It extends all the way from the base of the skull, continuing inferiorly down through the neck. Its inferior boundary depends on where the alar fascia eventually fuses with the visceral fascia, which usually happens around the level of the 7th cervical vertebra, C7, up to the 1st thoracic vertebra, T1. Therefore, it generally extends down into the superior mediastinum.
The clinical consensus highlights this retropharyngeal space as the primary gateway. It is the most common initial route for the spread of deep oral and cervical infections. It acts as the primary holding area.
Let's use a clinical scenario. A child has a severe, untreated tonsil infection, or an adult accidentally swallows a sharp fish bone that pierces through the back wall of their pharynx. The bacteria bypass the mucosal lining, breach the buccopharyngeal fascia, and gain entry into this retropharyngeal space.
And once the pus is in there, it begins to pool and expand. It is trapped between the pharynx in front and the alar fascia in back. The patient will present with severe neck pain, a stiff neck torticollis because the inflammation is irritating the nearby spinal muscles, and profound dysphagia difficulty swallowing because the expanding mass of pus is physically pushing the posterior wall of the pharynx forward, narrowing the airway and the food passage.
Right.
You might even see a visible asymmetrical bulge in the back of their throat if you look inside their mouth.
It is a severe emergency requiring surgical drainage and aggressive antibiotics. But as dangerous as a retropharyngeal abscess is, it is the space directly behind it that keeps cardiothoracic and head and neck surgeons awake at night.
Yes, space 4, the danger space. Now, I want to stop and plant a massive flag here, because this is where so many students and, frankly, even some practicing clinicians get confused. People constantly use the terms retropharyngeal space and danger space interchangeably in casual conversation. They blur the lines, but structurally and clinically, they are absolutely fundamentally distinct, aren't they?
They must be firmly distinguished in your mental model. The retropharyngeal space is located in front of the alar fascia. The danger space, clinically designated as space 4, is located entirely behind the alar fascia.
Let's define the walls of the danger space.
The anterior wall of the danger space is the alar fascia. The posterior wall is the true prevertebral fascia, resting tightly against the spine.
So the alar fascia is the sole dividing wall between the retropharyngeal holding area and the danger space.
Exactly, and the danger space has completely different vertical boundaries, which is what makes it so lethal. Like the retropharyngeal space, it starts at the base of the skull. But unlike the retropharyngeal space, which usually pinches off around C7 or T1 in the superior mediastinum, the danger space is wide open all the way down.
Oh, wow.
Yes, it extends unimpeded through the entire posterior mediastinum, reaching all the way down to the diaphragm.
It is a closed potential space stretching from the brainstem to the stomach. Now let's talk about mechanics. An infection doesn't just magically spontaneously generate inside the danger space. It's walled off. How does it get there?
It requires a sequential breach. To get into the danger space, an infection must first establish itself in the retropharyngeal space in front of it. As the pus pools there, the bacteria release selytic enzymes, and the sheer mechanical pressure of the abscess builds. The infection must then chemically erode or physically dissect through that thin, flimsy sheet of alar fascia.
So the alar fascia is literally the last line of defense between a severe neck infection and a catastrophic systemic event.
It is the final turnstile, and once the infection successfully melts through the alar fascia and enters space 4, all bets are off. There are no more fascial boundaries to stop it. The pus has a frictionless, gravity-assisted drop straight down into the posterior mediastinum of the thoracic cavity.
And what happens when a raging bacterial infection dumps into the posterior mediastinum?
It causes acute descending necrotizing mediastinitis. The infection surrounds the aorta, the esophagus, and the pericardium of the heart. The mortality rate for this condition, even with modern intensive care, aggressive surgical debridement in theater, and broad-spectrum antibiotics, is extraordinarily high. The barrier between a bad sore throat and a fatal heart infection is merely the microscopic thickness of the alar fascia. That is precisely why it is universally known as the danger space.
It is chilling when you trace the mechanics of it.
Okay.
Let's take a breath, step back, and move into the integration phase, bringing the systems together. We've talked about these deep vertical spaces, the retropharyngeal and the danger space. But going back to our opening scenario, how does a peripheral infection like a bad molar tooth or an infected tonsil actually reach the midline behind the throat? It has to navigate a horizontal network first.
It does. It has to travel from the lateral compartments into the midline. And the primary hub for that lateral transit network is the peripharyngeal space.
The peripharyngeal space. Conceptually, this is a massive area of loose connective tissue that surrounds the pharyngeal wall, both posteriorly and laterally. It lies deep to all the laminae of the investing fascia we discussed earlier, and critically, it freely communicates with the masticator space, the submandibular space, the parotid space, and the retropharyngeal space.
The text specifically highlights a crucial subdivision of this area called the lateral pharyngeal space, sometimes called the parapharyngeal space in clinical literature. Let's define its borders, because it is essentially the grand central station of deep neck infections.
Structurally, it is bounded medially by the buccopharyngeal fascia of the throat. Laterally, its wall is formed by the medial pterygoid muscle, the mandible, and the deep lobe of the parotid gland. It's shaped like an inverted pyramid with its base at the skull and its apex pointing down toward the hyoid bone.
And it contains some vital structures: the carotid artery, internal jugular vein, lower cranial nerves, and importantly, the styloglossus and stylopharyngeus muscles. But its clinical significance lies in its connectivity. If we think of the fascial spaces as a transit system, the lateral pharyngeal space is the central hub. Because of its vast vertical extent and its direct contiguous associations with the oral cavity, it is the most frequently infected secondary space in the head and neck.
Secondary space meaning the infection doesn't start there, it travels there.
Correct. Primary infections originating from dental abscesses in the lower molars, severe tonsillitis, infections of the tongue, or abscesses in the salivary glands, all of these peripheral pathologies drain into or directly perforate into this lateral pharyngeal space.
Wait, if the lateral pharyngeal space is grand central and everything is draining into it, there has to be a breaking point. It's surrounded by muscle, bone, and dense fascial layers laterally. If pus builds up there, it can't just expand infinitely outward through the jaw. It has to take the path of least resistance. Where do the trains go from Grand Central?
They go medially, and that is the terrifying part. As pressure builds in the lateral pharyngeal space, the pus seeks an exit. The weakest wall is the medial boundary, the buccopharyngeal fascia. The infection easily erodes medially, breaking through the buccopharyngeal fascia and spilling directly into the retropharyngeal space.
And we just established what happens next. From the retropharyngeal space, it's only one flimsy layer of alar fascia away from the danger space and the fatal drop into the mediastinum.
Exactly. The lateral pharyngeal space is the critical hidden transit hub that turns a localized peripheral dental abscess into a raging, systemic, life-threatening crisis. It facilitates the horizontal spread that leads to the fatal vertical drop.
Let's look at one final integrative pathway, and this one brings us back out of the deep spaces and onto the superficial surface of the face. We all grew up hearing the old wives' tale from our mothers about not popping a pimple in the danger triangle of your face. They said it could go to your brain.
Yes, I remember that.
But as we read in the clinical correlations of Chapter 22, it is not an exaggerated wives' tale. It is a documented anatomical and physiological fact. Let's define this zone. What is the danger area of the face?
Anatomically, it is the triangular area bordered inferiorly by the upper lip, laterally by the sides of the nose, and extending superiorly to the lateral corners of the eyes, just above the supraorbital ridges.
So basically your upper lip, your entire nose, and the space between your eyes. Now, the lethal risk here isn't about fascial planes splitting or hidden connective tissue corridors, is it? It's about plumbing. It's vascular. The text points out a fascinating, almost counterintuitive clinical phenomenon. The facial vein, the primary venous drainage for this area, has no valves.
This is a critical structural quirk. In almost all of your peripheral body, your arms, your legs, your veins have delicate one-way valves. These valves ensure that blood only flows in one direction, back toward the heart against gravity. If pressure increases, the valves snap shut to prevent backflow, but the facial vein completely lacks these valves.
Why? Why would we evolve a valveless vein right next to our brain?
The prevailing physiological theory relates to thermoregulation. The valveless system in the face allows for bidirectional blood flow. In instances of extreme hyperthermia, cooler venous blood from the surface of the face can theoretically flow inwards to help cool the arterial blood supplying the brain. But this thermoregulatory advantage comes with a massive, lethal vulnerability regarding infection.
Because without valves, blood flow can easily reverse direction depending on local pressure gradients. So let's map this out clinically. What does this anatomical quirk mean for the teenager aggressively squeezing a painful boil or severe cystic acne pimple on the bridge of their nose?
Well, when you violently squeeze a boil in this danger area, you are applying immense mechanical pressure to an enclosed space filled with bacteria, inflammatory mediators, and pus. Because there is no fascial layer holding things steady, and because the local venules are delicate, that mechanical force can easily rupture the microscopic boundaries, forcing infectious material and thrombosed, clotted blood directly into the local tributaries of the facial vein.
And because there are no valves to stop it.
Because there are no one-way doors, this highly contaminated, bacteria-laden blood does not have to flow downward to the neck. Instead, pushed by the mechanical pressure of the squeeze, it can flow retrogradely backwards. It travels upwards and inwards, communicating deeply through the superior and inferior ophthalmic veins located in the orbit of the eye, or via the deep facial vein into the pterygoid venous plexus.
And where do the ophthalmic veins of the venous plexus eventually drain their blood?
They drain directly into the cavernous sinus. The cavernous sinus is a massive, incredibly complex dural venous sinus. It is a pool of venous blood located deep inside the cranial vault, sitting directly at the base of the brain, flanking the pituitary gland.
I need to visualize the severity of this. You pop a pimple on your nose. The mechanical pressure forces staph bacteria into the vein. The vein has no valve, so the bacteria flow backwards through your eye socket, straight through the base of your skull, and dump directly into a pool of blood that is intimately bathing the base of your brain.
Yes, that is the exact anatomical pathway, and the resulting infection inside the skull causes a condition called cavernous sinus thrombosis.
What happens mechanically when that sinus gets infected?
The body attempts to wall off the infection by forming massive blood clots within the cavernous sinus. But this sinus is the primary venous drainage pathway for the brain and the eyes. When it clots off, venous blood cannot escape the skull. The pressure skyrockets. This leads to profound cerebral edema swelling of the brain.
Oh, that's disastrous.
And furthermore, several critical cranial nerves, specifically nerves 3rd, 4, V1, V2, and 6, which control eye movement and facial sensation, run directly through the cavernous sinus. The pressure paralyzes these nerves, causing the patient's eyes to bulge, freeze in place, and go blind. Without incredibly rapid, aggressive intravenous antibiotics and heavy anticoagulation, the infection and pressure will spread to the brain tissue itself, leading to meningitis, coma, and death. Squeezing a pimple in that specific anatomical triangle is genuinely lethally perilous.
That is absolutely wild, and it perfectly encapsulates our anchor for today's entire deep dive structure dictating clinical outcome. A tiny microscopic structural omission, the evolutionary lack of venous valves for the sake of thermoregulation, creates a direct, unobstructed pathway for a superficial, cosmetic blemish to become a lethal intracranial catastrophe. Anatomy is never just trivia. It is destiny.
Well said.
Well, we have covered an incredible amount of dense, complex ground today. We've gone from the sliding superficial skin to the lethal depths of the mediastinum. Let's move into our outro and synthesize our key takeaways from Chapter 22. Number 1, fascia is not inert biological packing material. It is a dynamic system that organizes and separates structures, allowing for frictionless movement while simultaneously creating distinct, restrictive functional compartments.
Number 2, the deep cervical fascia has 3 key architectural layers: the investing layer, which is the outer collar, the pretracheal layer, the visceral wrapper, and the prevertebral layer, the spinal cylinder.
Number 3, the carotid sheath is a critical composite neurovascular tunnel formed by contributions from all 3 deep layers, directly connecting the base of the cranium to the mediastinum of the chest.
Number 4, fascial spaces, though often just potential clefts of loose connective tissue in a healthy state, act as unimpeded highways, allowing the rapid directional spread of severe infection.
Number 5, the retropharyngeal space, located between the buccopharyngeal fascia and the ular fascia, is the primary initial gateway for oral and cervical infections to spread deeper into the neck.
Number 6, the danger space, or space 4, is structurally distinct. Located strictly behind the ular fascia and in front of the prevertebral fascia, it provides a direct, unimpeded, gravity-assisted path straight down to the mediastinum.
Number 7, the masticator and submandibular spaces are densely packed, high-pressure, frequently infected sites that serve as the primary origins for complex multi-space spread.
And number 8, the peripharyngeal space, specifically its lateral pharyngeal subdivision, connects multiple anatomical regions horizontally, acting as the grand central station, routing superficial infections deep into the midline.
Excellent summary. Now, to truly cement these concepts, we're going to run through some learning reinforcement. We have 6 single best answer, or SBA, questions based on the spatial, functional, and clinical reasoning we've just explored. I strongly encourage you listening to pause the audio, visualize the anatomy, and commit to an answer before we break it down. Let's test the mental model we just built. Here we go.
Ready when you are.
Okay, let's run a quick diagnostic on my spatial awareness. Question 1. I'm visualizing the posterior wall of the throat. Which specific fascial layer forms the posterior boundary of the retropharyngeal space and simultaneously forms the anterior boundary of the danger space? Is it A, the pretracheal fascia, B, the buccopharyngeal fascia, C, the ular fascia, or D, the prevertebral fascia?
Well, the correct answer is C, the ular fascia. As we heavily emphasized, the ular fascia is the crucial paper-thin divider between these 2 lethal spaces. It is the final turnstile. For context, the buccopharyngeal fascia is the anterior wall of the retropharyngeal space, while the true prevertebral fascia forms the posterior wall of the danger space.
Brilliant.
Hmm.
Moving to the floor of the mouth.
Me.
Question 2. A patient presents in A&E with an aggressive infection that is rapidly spread from the superior sublingual space. To physically reach the inferior submandibular space via gravity, the infection must pass around the posterior free border of which specific anatomical structure? Is it A, the anterior belly of the digastric muscle, B, the hyoglossus muscle, C, the mylohyoid muscle, or D, the stylomandibular ligament?
The answer is C, the mylohyoid muscle. Recall our detailed warehouse mezzanine analogy. The mylohyoid muscle acts as a horizontal sling that divides the submandibular compartment into the superior sublingual space and the inferior submandibular space. Crucially, these two compartments communicate freely at the open posterior margin of this muscle.
Spot on. Question 3. We talk about the high-pressure engine room of the jaw. Which of the following structures is not anatomically contained within the rigid boundaries of the masticator space? Is it A, the master muscle, B, the maxillary artery, C, the submandibular gland, or D, the mandibular nerve, V3?
The answer is C, the submandibular gland. The masticator space is formed by the splitting of the investing fascia at the mandible and tightly contains the muscles of mastication, the maxillary artery, the mandibular nerve, and the buccal fat pad. The submandibular gland is located much further inferiorly, enclosed by its own entirely separate split of the investing fascia below the jawline.
Good distinction. Now, think about facial trauma. Question 4. A patient suffers a superficial laceration to their cheek from a sharp object. The wound gapes widely, exposing the muscle beneath. This severe gaping is primarily due to the anatomical absence of which distinct layer in the face. Is it A, the superficial fascia, B, the epidermis, C, the deep fascia, or D, the platysma muscle?
The correct answer is C, the deep fascia. Unlike the limbs or the neck, the superficial fascia of the face lacks any underlying typical deep fascial layers to bind it down to the bone. The muscles insert directly into the skin, which is why facial incisions tend to pull apart and gape, requiring meticulous, tension-bearing subcutaneous suturing to minimize aesthetic scarring.
Question 5, returning to the plumbing. An infection in the danger area of the face spreads retrogradely, backwards, the cavernous sinus inside the skull. This lethal retrograde spread is primarily facilitated by which highly specific anatomical feature of the facial vein? Is it A, its unusually large diameter, B, the complete absence of valves, C, its close proximity to the internal carotid artery, or D, its direct connection to the jugular venous arch?
The answer is B, the complete absence of valves. The facial vein evolved to be valveless, likely for thermoregulation, allowing blood to flow bidirectionally based on pressure. Unfortunately, this allows infected thrombosed blood to easily flow backwards against normal drainage patterns, traversing through the ophthalmic veins directly into the cranial dural venous sinuses.
Final test of the model, question 6. We discussed a fibrous roadblock between the salivary glands. The stylomandibular ligament, which critically separates the parotid gland from the submandibular gland, is an architectural condensation derived from which larger fascial layer? Is it A, the superficial cervical fascia, B, the deep lamina of the investing fascia, C, the petracheal fascia, or D, the prevertebral fascia?
The answer is B, the deep lamina of the investing fascia. As the structural investing collar sweeps up and splits to surround the parotid gland, its deep leaflet condenses into a thick band stretching from the styloid process to the mandible, forming this vital clinical boundary.
Excellent work. If you nailed those, your 3D spatial model is locking into place perfectly. Now, before we read off the formal closing details, we want to leave you with one final, provocative thought to mull over. We have spent this entire extensive deep dive discussing how these loose connective tissue spaces, these hidden corridors, act as high-speed highways for deadly infections. From a purely defensive standpoint, it seems like a massive biological design flaw, a lethal vulnerability built right into our core. But why do they exist at all?
That's a great question.
These fascial clefts did not evolve to kill us. They evolved primarily to facilitate the frictionless, massive, multi-directional movement required for basic mammalian survival. The viscera must glide smoothly against the rigid spine every time you swallow. The massive jaw muscles must expand and contract violently without tearing the skin. The face must move freely to communicate. So what does the modern reality of deep space infections, which so often stem from diet-induced dental decay or modern medical immunosuppression, tell us about our evolutionary biology? It highlights a profound evolutionary trade-off.
It really does.
We traded structural, impregnable, compartmentalized defense for the vital dynamic mobility of the throat and face. We are exquisitely built to speak, to swallow, and to express human emotion, even if that very design leaves a hidden corridor wide open for our own destruction. It is something profound to think about the next time you simply swallow a sip of water.
A fascinating, humbling perspective on the hidden costs of our own remarkable anatomy.
Here are the details of this episode.
Fasciae of the head and neck, the hidden planes of spread, byline. Not all danger lies in what you see, sometimes it lies in the spaces in between. Episode description. This chapter is not about muscles, bones, or vessels. It is about the architecture that surrounds them.
Subtle, often ignored, but clinically decisive, because it does something quietly powerful. Because it does something quietly powerful, it creates pathways for movement, for containment, and for disease. Because it does something quietly powerful. As described in the opening section, fascia forms connective tissue sheets that surround in separate structures, while the spaces between them allow rapid spread of infection. Because it does something quietly powerful. Key takeaways. Because it does something quietly powerful. Fascia organizes and separates structures. Because it does something quietly powerful. Deep cervical fascia has 3 key layers, because it does something quietly powerful. Carotid sheath is a critical neurovascular tunnel, because it does something quietly powerful. Fascial spaces allow spread of infection, because it does something quietly powerful. Retropharyngeal space, a gateway to deeper spread, because it does something quietly powerful. Danger space, direct path to mediastinum, because it does something quietly powerful. Masticator and submandibular spaces are common infection sites, because it does something quietly powerful. A peripharyngeal space connects multiple regions,